Welcome to Section 2 of Gastrointestinal Anatomy. In this section, we will discuss hernias and the inguinal canal. Let's get started. Let's start by getting our bearings straight. The inguinal ligament starts at the anterior superior iliac spine, or ASIS, which is in this area, and the ligament continues distally and medially until it reaches the pubic tubercle, down here. Now let's take a closer look at the actual structures in this area. This image shows the femoral triangle down here below. We see the borders of the triangle demonstrated right here. And this was discussed in great detail in the cardiovascular anatomy chapter. Our attention is mainly going to be focused above this triangle, in this region. But we will return to the femoral triangle later in this lecture when we discuss femoral hernias. So again, now let's focus above the inguinal ligament. These two vessels right here represent the external iliac artery and vein. And as these descend down and cross the inguinal ligament, they become the femoral artery and the femoral vein. But before they cross the inguinal ligament, they send off branches. And these are the inferior epigastric branches, inferior epigastric artery and inferior epigastric vein. And to the right, you can see the rectus abdominis muscle. And with that, we've identified each border of the Hesselbach's triangle. On the medial side, the rectus abdominis muscle, that's the medial border. The inferior epigastric artery and vein, that's the superior border. And the inguinal ligament, right here, forms the lateral triangle. So, Hesselbach's triangle. And this is listed again right here. The inguinal ligament is the inferior border, the inferior epigastrics form the lateral border, and the rectus abdominis muscle forms the medial border. Now, direct inguinal hernias occur within the triangle, while indirect inguinal hernias occur lateral to the triangle. So I'll write a big D for direct right here, and for indirect, I'll write a big I. It's lateral. To reinforce this anatomy, here is Hesselbach's triangle from the surgeon's view. To orient yourself, picture you are a surgeon using a camera to look inside the abdominal cavity, and this is the anterior side up here. In front of us, we can see the rectus abdominis muscle, labeled here, and we can also see the epigastric vessels, as well as the inguinal ligament, which attaches here at the ASIS and also at the pubic tubercle, also labeled here. So now we've formed the borders of the triangle. Now let's discuss the three hernias you need to know about. Here is the table showing the details you need to know about each one: indirect inguinal hernias, direct inguinal hernias, and femoral hernias. Let's start our discussion by talking about indirect inguinal hernias. So here are the inferior epigastric vessels, and indirect hernias will occur lateral to these. So I will write an I up here to indicate indirect, which can occur in this region. And what happens is intestines will actually protrude through this internal inguinal ring, which is also called the deep inguinal ring. Now imagine the intestines entering here and squeezing through the inguinal canal and continuing down until they reach the external inguinal ring, which you can see labeled here, which is also known as the superficial inguinal ring. Going back to the surgeon's view, we can see that indirect hernias will occur lateral to this triangle in this region. Going back to the intestines, they will herniate through the inguinal canal and be covered by all of the layers of the spermatic fascia. To make sense of this concept, let's dive deeper into the inguinal canal. In females, the inguinal canal will convey the round ligament of the uterus. However, in males, it conveys the spermatic cord, which we actually showed with this image, the spermatic cord. And the inguinal canal is larger in males, which means it's more likely to produce hernias. So when the intestines push through here, the intestines will be covered by all the layers of the abdominal wall. To better visualize this, let's take an axial cut through here. This will allow us to see all the layers. This is an image showing the abdominal wall and all its layers. And this is an anterior perspective, and we're looking at the right testicle. And the intestines would be up here in this region. And you can see the skin wrapping all the way around, represented as this orange line. And up here would be the peritoneum. And now we can talk about those layers. We start with the transversalis fascia, then the transversus abdominis muscle, the internal oblique muscle, the external oblique muscle, and finally the external oblique fascia. Now that we've covered the important layers, let's discuss the tunica vaginalis. If you look up above, you can see the black line coming from the peritoneal cavity. This invagination is called the tunica vaginalis. In utero, this conveyed the spermatic cord. Then, after the testicles and all the other important contents have traveled down, this would close up and seal itself off. At least, it's supposed to do that. If it doesn't seal up, this is known as a patent processus vaginalis. And this indicates that there's an opening to the abdominal cavity. So if pressure is high in the abdominal cavity, then the intestines can push through this deep ring, also called the internal ring. And the intestines would then travel down this patent processus vaginalis and then go through the superficial or external ring. At that point, it would be in the scrotum and adjacent to the testis. Going back to the table, indirect inguinal hernias are the most common hernias overall. With that in mind, they occur more in men than women, and they can also occur in infants and heavy lifters. It occurs in infants if the canal doesn't close, and it occurs in people that are lifting lots of weight because it can reopen the processus vaginalis. And since the intestines protrude through the patent processus vaginalis, that means that it must go through the deep and external rings, or the internal and external rings. And the deep ring is lateral to the inferior epigastrix. Notice in the notes here I've written MDs don't lie. L for lateral and I for indirect. And what's it lateral to? The inferior epigastrix. So MDs don't lie. Lateral hernias are lateral to the epigastrix and they are indirect. LI. Now I want to draw your attention to the spermatic fascia column. Notice we have written here that it's covered by all 3 layers of the spermatic fascia. I mentioned all 3 layers before, but what does that mean exactly? What is the spermatic fascia? Let's talk about that. Recall these 3 muscular layers on the left: the transversus abdominis muscle, the internal oblique muscle, and the external oblique muscle, and also the fascia associated with the external oblique muscle, which is the external oblique fascia. And recall the fascia associated with the transversus abdominis muscle, the transversalis fascia. The transversalis fascia will continue medially and wrap around the testis and then become the most internal layer of the spermatic fascia. So here it is called the internal spermatic fascia. The external oblique fascia follows a similar pattern, and it's called the external spermatic fascia. But what about this middle layer? Well, this is a continuation of the internal oblique muscle, and it's called the cremaster muscle, or cremasteric fascia. So in summary, the transversalis fascia becomes the internal spermatic fascia. The internal oblique muscle becomes the cremaster muscle and the cremasteric fascia. And the external oblique fascia becomes the external spermatic fascia. So notice I've actually spelled out IceTie. I-C-E-T-I-E. And to make all of that clear, let's look at this slide. The internal spermatic fascia came from the transversalis fascia. The cremasteric muscle and its fascia came from the internal oblique muscle. We didn't really draw the fascia in that image, but if you know that the cremasteric muscle comes from the internal oblique muscle, you're golden. And the external spermatic fascia comes from the external oblique muscle. It's important to pair these up, internal spermatic fascia with the transversalis fascia, and so on. So medical students have found this is a very helpful memory hook. IceTie. So I-C-E for ice, and here we're dealing with the spermatic fascia, so internal spermatic fascia, and then we have the cremasteric fascia and the external spermatic fascia, and tie for transversalis fascia, internal oblique muscle, and external oblique muscle. So IceTie. The internal spermatic fascia comes from the transversalis fascia, the cremasteric fascia comes from the internal oblique muscle, and the external spermatic fascia comes from the external oblique muscle. IceTie. This image shows an anterior view of a right-sided indirect inguinal hernia. See how the intestines have pressed through the patent processus vaginalis. So the intestines have traveled through the deep inguinal ring and the superficial inguinal ring. And as mentioned before, the intestines will be covered by all 3 layers of the spermatic fascia. Remember ICE, the internal spermatic fascia, the cremasteric fascia, and the external spermatic fascia. Now let's do a question to apply what you've learned so far. A 36-year-old obese male presents with a painless mass in his scrotum. He works at a factory that requires him to lift heavy boxes. The first time he noticed the mass was last week after lifting something heavy. The physician palpates the scrotum. From the skin to the testis, what layers of the spermatic fascia is he feeling? What structures give rise to each of these layers? So the physician is palpating a scrotum. Let's just draw a little scrotum here. And we are asked to list the layers from superficial, the side with the skin down here, and then let's show a testis right here, and this would be the deepest layer. So from superficial to deep, what layers of the spermatic fascia is he feeling? Well, recall the 3 layers of the spermatic fascia were ICE. So external spermatic fascia would be the most superficial, so I'll write E right here, and the cremasteric fascia would be next, and the internal spermatic fascia would be the deepest. So that answers the first part of the question. What layers of the spermatic fascia is he feeling? The next question, though, asks what structures give rise to each of these layers. This is where the tie comes in, T-I-E. And the E is easy because it's the external oblique muscle. And this cremasteric muscle and fascia comes from the internal oblique muscle. And the internal spermatic fascia comes from the transversus abdominis muscle. So this is why it's important to know IceTie. And that answers our question. And once again, indirect hernias are covered by all 3 layers of the spermatic fascia. And remember these layers with IceTie. Now let's focus on direct inguinal hernias. These will protrude through the transversalis fascia. And we specifically wrote on this table that the intestines protrude through a weak transversalis fascia. What kind of people have weak transversalis fascial layers? Old people. So if you look over on the right column, we can see that direct inguinal hernias often occur in elderly people who have weak transversalis fascial layers. And which rings do the intestines protrude through? the external or superficial ring, and that's the only ring they protrude through. This is a very important point. And they occur medial to the inferior epigastrics, which means they occur within Hasselbalch's triangle. And strangely, these are covered only by the external spermatic fascia. Here is an image depicting a direct inguinal hernia. And this image will help you make sense of the fact that the intestines are covered only by the external spermatic fascia. Now, the internal spermatic fascia and the cremasteric fascia, so the blue line and the red line, which you can see right here, combine to form the conjoint tendon as they move medially. And you can more easily see this on this image, where we see the conjoint tendon right here, which again is a confluence of the internal spermatic fascia and the cremasteric fascia. In a direct inguinal hernia, the intestines go directly through the abdominal wall, which you can see them doing right here. And basically, they hit the conjoint tendon. In essence, though this is a slight oversimplification, the intestines split the conjoint tendon from its precursors. The internal spermatic fascia and the cremasteric fascia have actually pushed these two layers this way, and the conjoint tendon right here this way. So now you can see how the intestines have basically put themselves just beneath the external spermatic fascia. And that's why the intestines in direct inguinal hernias are said to be covered only by the external spermatic fascia. And that makes sense. It didn't travel through the deep inguinal ring. It just went straight to the superficial or external ring. And by doing that, it split the layers and got covered only by the outermost layer. And going back to this table, we can see that the direct inguinal hernias are covered only by the external spermatic fascia. And where do they occur? They occur medial to the epigastric arteries, which is where MDs comes from. Medial, again, medial to the epigastrics, and D for direct. If you can remember MDs don't lie, you can remember that direct hernias are medial to the epigastrics, which means they're within Hasselbalch's triangle, as we've written. And you'll also remember that indirect hernias are lateral, or outside Hasselbalch's triangle. Now let's do a question to apply what you've learned so far. A 41-year-old woman is found to have a direct inguinal hernia on the left side. A branch of the external iliac artery supplies the abdominal wall. Where are the intestines protruding through the abdominal wall in relation to this vascular branch? So we're told that this is a direct inguinal hernia, which we know occurs within Hasselbalch's triangle. And what forms Hasselbalch's triangle? The rectus abdominis muscle. So we'll draw two right here. And this is the patient's right, and this is the patient's left. And then we have the inguinal ligament right here, on both sides, of course. And then the lateral border is the inferior epigastric vessels. And going back to the question, we're told to think of the external iliac artery and one of its branches that supplies the abdominal wall. Now, what branch are we referring to here? The inferior epigastrics. That's the branch from the external iliac artery that will supply the abdominal wall. And since this is a direct inguinal hernia, where in relation to these inferior epigastric vessels will the hernia occur? It will be medial down here. Remember the phrase, MDs don't lie. Direct inguinal hernias occur medial to the inferior epigastrics within the triangle. The last thing to talk about are the femoral hernias. In femoral hernias, the intestines will herniate through the femoral ring. The femoral ring is medial to the femoral vessels, and this occurs more often in women than men. However, it's super important to remember that indirect inguinal hernias are still more common, even if you are a woman. So notice right here we have the femoral vessels, the artery and the vein, and just medial to those is the femoral ring, right in here. Going back to the surgeon's view, we can see that femoral hernias occur here, beneath the inguinal ligament. So the femoral ring would be in this region indicated by the circle. Going back to this table, we can see that femoral hernias occur below the inguinal ligament because they're not even associated with Hasselbalch's triangle. They're not medial or lateral to it. It's just not associated with it. They occur below the inguinal ligament, so way below Hasselbalch's triangle. We don't consider these inguinal hernias. We call these femoral hernias. And they occur medial to the femoral artery and vein. And these vessels actually form what's called the femoral sheath. So you could also say that femoral hernias occur medial to the femoral sheath. And the spermatic fascial layer isn't relevant here because femoral hernias are not associated with the inguinal canal, so not applicable. And they occur more often in women than men. Now let's do a question to apply what you've learned. A 68-year-old woman presents to the emergency department complaining of right lower quadrant abdominal pain. After thorough evaluation, she is found to have an intestinal hernia near her right inguinal ligament. What type of hernia is most consistent with this patient's presentation? Now, what three hernias occur near the inguinal ligament? We have the indirect inguinal, direct inguinal, and femoral hernias. So what's most likely in this patient? An indirect inguinal hernia. Because she's a woman, you may be tempted to say that she has a femoral hernia. After all, if a patient has a femoral hernia, they are more likely to be a woman than a man. We've shown that down here. However, with that in mind, indirect inguinal hernias are the most common in either gender, as we've written up here. And that concludes this section.